to pressure injury prevention, addressing the use of silicone foam dressings. My name is Catherine Milne. I'm an adult nurse practitioner and wound care nurse practitioner. I practice at Connecticut Clinical Nursing Associates in Bristol, Connecticut. I'm also affiliated with the Bristol Hospital Wound Center for Healing and Hyperbaric Medicine. I have a very unique position because I do practice across the continuum. So I see people in acute care, long-term care, do my 1 day a week at the wound center, and I also will make house calls for the truly homebound with wounds. I do want to have some disclosures today. I am on the Speakers Bureau of 3M and KCI, Convatec, Smith & Nephew, and I am a member of the International Consensus Panel for Device-Related Pressure Ulcers, the Secure Prevention. The program today is provided by the North American Center for Continuing Medical Education and HMP Global Company, and it is supported by an educational grant from 3M Healthcare Medical Solutions Division. I do want to thank you for joining us today. We have several learning objectives. The first one being, we are going to assess the clinical and cost effectiveness of silicone foam wound dressings in pressure injury prevention and management. And we're going to examine the features and application of silicone foam dressings in pressure injury prevention. And we're going to explore some cases using silicone foam dressings in pressure injury prevention and those on challenging locations like the sacrum. I just want to review, because some people that come to these programs are getting just into wound care, and those of us who are very, very experienced just want to pick up a nugget or two. So just to review, so we're all on the same page, the definition of a pressure injury is a localized damage to the skin and or off underlying soft tissue. It's usually over a bony prominence, or it's related to a medical or other device. So we're going to talk about some of the historical perspective here. And I know people don't think that it has anything to do with foam dressings, but it really does. So when we think about the pressure studies, the first one is Landis, and that was done in about 1930. And it determined that capillary closing pressure of 32 millimeters of mercury. And what he did was he used a blood pressure cuff, and he found out that the tissue became ischemic above that number. Well, it's very interesting. We still see people use that number. And when you think about that blood pressure cuff, it's really not very hard to get to 32. We currently use what I call the nurse on the stick, a machine. Somebody wraps the cuff up and then pushes a button. But in the old days, we would wrap a blood pressure cuff up and then manually pump up the cuff with air. And really, it would take 3 or 4 maybe pumps of your hand on that bulb. So it's not really very much. However, this number 32 is kind of stuck with us. And when you think about people who are manufacturers of mattresses, they say, oh, all of our pressure studies show that we are below 32 millimeters. And actually, we wish it was all that simple. So we do know there's been some changes and the science has progressed, which has been really wonderful. And Kosiak in 1959, which is still eons ago, what he decided to do was we are going to load tissue, and he used animals with weights that were consistent. And then he just varied the duration. And what he found is then he did a punch biopsy and he looked at the histology of the cells. And he found that you would have changes in your tissue at 60 millimeters of mercury of load in 1 hour. So, now we're starting to see things changing a little bit. So we do know that pressure equals force over area. And when you look at this picture, you can see if you change that surface area pressure and make it, as we see on the right, more distributed along that surface, you don't inflect very much into that tissue. If you take that same weight and put it on its side, again, you have a less surface area pressure. So you have increased force and you're going to indent that tissue even further. So that has a lot to do with when we think about how we can mitigate surface area pressures on our patients. And then we found out about Hussein's work about tissue tolerance. And actually, this is really interesting because we kind of forgot about it for a long, long time. But it's really the condition of the skin and its supporting structures that is this patient's own ability to do the pressure equal force over area, redistribute that applied pressure. Now, the interesting thing that Hussein found is that if you keep on hurting the tissue or sensitizing the tissue over and over and over again, you need less pressure to cause that same kind of injury. And so that's really important too, because if you think about all of our patients and how we turn them side to side to side to side to side, and all we're doing is, again, we are giving them the same amount of pressure, but we've already sensitized them. So that's why we're seeing some patients that we're saying we've turned them, we've done this, we've done that, and they're still having a problem. And that's because their tissue tolerance has been sensitized. Dehydration can really impact tissue tolerance. And I always tell my skilled nursing facility staff, please, when you send your patient out to the ED, make sure their heels are up in the air. They're probably already compromised. They may have a problem with their blood pressure. They may be dehydrated. And when they get, into the ambulance or they get to the ED, the heels are not their prime concern. And so they may forget about it. And that tissue tolerance is enough to give them a heel pressure ulcer down the road. So let's look at that triad. Okay, so again, we know we have to have tissue ischemia, right? So we need a duration of a load. We need the intensity of that load. And then it all depends on that patient for that tissue tolerance. We do know that the low pressures over a long period of time can be just as damaging as high intensity pressure over a short period of time. So again, we have to be very cognizant of where we are positioning our patient and what surface they're on and what kind of patient we really have in terms of their own tissue tolerance. So I think our biggest leap in terms of pathophysiology has come with Amit Geffen's work in 2007. So he was the first to really identify this surface skin interface pressure that we are always refer to. And then he also found out that the external loads cause more damage deep down as compared to the superficial capillaries. And that's really important too, as we learn more about deep tissue injury. And there are different pressure gradients along that same vessel. So you may have some true injury and ischemia and cell death in one part of that vessel, and maybe just a little bit of ischemia, but then get some reperfusion issues when the vessels open back up again. And he did caution that measuring these surface interface pressures do give us a false sense of security, again, because the superficial capillaries are not what is happening deep down in the muscle area. And he also said, you know what, shear's an issue. He called it strain, and it only can happen in the presence of pressure. So Dr. Spriegel, and Dr. Sonnenblum, who are physical therapists, actually have done some other great things in terms of identifying shear and strain. And so what they did, again, is strain is this function of how that tissue is deformed. And so if you have something that, again, almost that same concept of pressure equal force over area. So if you have something that is a little bit, has more surface area, your strain is going to be less than something that's very, very pointed. And you can see that in this diagram here. Now, the other thing is that you are going to see strain further out from where the actual load is applied to the patient. And that's very important, especially when it comes to foam dressings. So farther away you have from your insult, your pressure insult, you will have strain, but it will be less. So you have to think about that when you are thinking about applying or trying to figure out a size of a dressing. Foam dressings come in many shapes and many different sizes, and so does your strain. So you have to think about what has been applied to that patient, where that strain is most deformed, which would be most at the center of that area, but we have to think about the strain and the stress that's further out. So if we don't cover that area with a foam dressing, we are going to, again, have that concept of re-injuring that area will decrease that tissue tolerance over and over again. So we talk about just, having enough dressing to cover the wound. We actually need a little bit more of the dressing to actually cover this shear strain that has been affected, so we don't impact and sensitize or allow our sensitized skin tissue tolerance to actually break down itself. So actually, when we started to take a look at Geffen's work, so he did a lot of computer modeling where he put patients or people, real people, in the MRI, and he's to study deep tissue injury in the gluteus muscle. So he did the MRI, and he ended up, slicing that MRI down so you could see the ischial tuberosities and the muscles of the buttocks and identify the fat. And you can see that fat is the bright area in that second picture. Then what he did was apply computer modeling to reproduce these, the anatomy and the impact of certain positioning and shear and strain in these computer simulations. So he was actually able to show that there is in different intensities deep in that muscle area that we wouldn't have normally seen because our skin, the superficial layers, are not showing it to us. So microclimate is another term, and it has been alluded to in Dr. Geffen's work, but in many people's work. And that is really the climate in the local region. And then that differs from the climate from the surrounding region. And it really is a combination of both temperature, humidity, and airflow. And so when you have an imbalance, whether that be a very, very dry skin or underhydration, or very, very moist skin, that actually will impact how shear or strain stress is accommodated in that tissue. So we also know that there is an impact in increased temperature. So increased temperature will increase your blood flow, which is always a good thing, right? But it also will increase your sweat gland activity. And when you sweat, that will actually change perhaps or possibly the pH of your skin. It can change the bacteria on your skin, and it also will change the coefficient of friction on your skin. So how you react to external devices or the presence of clothing or whatever that's on your skin. And so we do know that local humidity will increase oxygen needs of that local area of skin. And that's important too, because if you have a patient who is hypoxic, they don't have the ability to vasodilate, or they may vasodilate, but they're not going to get the oxygen needs that they require to keep that skin healthy. Now, I don't know if you've ever, put your hand in a glove. I'm sure we all have in the last year and a half. And, so a lot of times our hands are sweaty. And then I'm sure we all have put on gowns and face masks and face shields over the last year. Some of us have used PAPR also, and we're hot, right? We are hot and we're sweaty. And what has happened to our skin in the last year? We have all had problems with some type of breakdown or irritation. We had to get used to it. We had to adjust how we did our things. We all started drinking a lot more water. And So just the impact of increased temperature can impact even us healthy people and our skin. So once you have a local temperature increase, it increases the stiffness of the skin around the area. And it also takes that epidermal dermal junction and you start to not have that adhesion. And then again, because you're starting to slip and slide between the two layers, that also can lead to injury. Then we have microclimate challenges, and we have underhydration and we have overhydration. So we have to remember, and we don't really appreciate underhydration enough. But if you think about it, we deal with this every single day. We're washing our hands, we're washing them more than we ever probably have, and then we're using a ton of alcohol. And so what we're seeing is that we are drying out our skin and we're getting these mechanical damages, we're getting fissures, we're getting cracks. And when you have that, you actually get inflammation. And because of that inflammation, your epidermis kind of gets a little upset and they get really tight and it gets, very stiff. And when you have that stiffness, you actually increase your coefficient of friction on your skin. And we know that when you change the coefficient of friction on your skin, you are more apt to get a pressure injury. And we don't think about this enough. We need to be drinking more water. We need to be hydrating our patients more often. And when we have a patient with a lot of dry skin, we may need to protect this with a foam dressing just so we can actually improve our moisture content. And on the other side of this seesaw is overhydration. And we think about this a lot more than underhydration because we're worried about sweat and incontinence and wound drainage. But when you have these factors impact the skin, your cells swell up, right? And so that mortar in between the cells, those epidermal cells, so that's natural moisturizing factors and lipids, they're disrupted, they're squeezed out. And when you have that barrier disruption, what happens is that all the skin irritants, so whether that be fecal and urinary enzymes, whether that be yeast, bacteria, whether that be the changes in pH that are accompanying all this, that actually helps break down that skin. And that's what gives you the big problem. And now let's go on to humidity. So when you have a humid condition, you actually, again, increase the susceptibility to injury and irritants. And that's all because of that frictional coefficient. And interestingly enough, in women, humidity is more detrimental than in men. We do know that when you increase that frictional coefficient, you have more slip and it decreases your ability to tolerate shear and strain. And when you actually occlude something that's humid, so think about those CPAP masks and they're occlusive, the patients are sweating underneath, you actually will increase inflammation. You also see that when you're using briefs that get full, do not wick the moisture away. When you have that, you will also have a change in your local microbiome of your skin, and especially seen is the increase in Candida species there. And we have to think about the sources of humidity contributing to pressure injury. I think we're all very comfortable knowing that incontinence will do this, as will wound exudate. But we have to think about occlusive clothing. And these older people, especially in long-term care in the home health setting, they're cold all the time. And they're wrapping themselves up in layers and layers and layers. And guess what? They're sweating. And so what happens is that there are actually causing more skin damage. It's really hard to convince them to use less clothing or to get clothing that wicks moisture away. The same thing about body-worn products. So we're looking at briefs and those kind of issues. And so there's a great article on body-worn products in the Journal of WOCN. You probably should read it because it really helps you figure out what might be the best thing for your patient. But while you're trying to read that and hunt that article down, you really should be thinking about those also may be contributing to pressure injury if it is not the correct body-worn product. Okay, let's talk about pressure injury. Is it top down or bottom up? Well, you know, the definition of friction is the force that resists motion when the surfaces of one object is on top of the other. And that leads to that coefficient of friction that I've already mentioned. So think about, and that's really just the measurement of friction between two surfaces. And we do like friction because if we don't have anything, we are on our bottom, like slipping on the ice, because there is no friction. But when there's a lot of friction, especially on the skin, you know, that's a great example of how you get a skin tear. Okay, let's talk about frictional forces now in the real clinical setting. So this is a 45-year-old male who is morbidly obese. He's over 460 pounds, and he was born with a hip issue, and his parents never wanted any surgical intervention, and he has not wanted to pursue it either. But literally when he walks, he swings this one leg out and then over and down. So what happens because of his morbid obesity is between his buttocks, which are moist anyway because of sweat, he actually has friction, and he has actually given himself a pressure ulcer just from these frictional forces of ambulation. This is where a foam dressing, a multi-layer foam dressing is perfect because you are reducing that frictional force on the skin. And if the multi-layer foam dressing is constructed correctly, you will actually help reduce humidity and absorb any of that extra moisture in the area. So how does one get a pressure injury? Well, everybody say, oh, you know, they just lay down too much. And I think a lot of families think that because they're seeing Dr. Google. But really, it's really tissue and cellular deformation. And it can be complicated by reperfusion injury and lymphatic destruction. And again, shear and friction play a big force in this. We've seen that picture where you will have shear not only at the site of injury where the pressure is a compression or compressed, but also further away. And when you have that compression, that shear strain will be impacted by your microclimate, the amount and type and age of that soft tissue, and then the shape of the bone. That's really important. So, and again, if you add that friction, makes things a whole lot worse. So you are really looking for a multi-layer foam dressing that impacts both the coefficient of friction and heat, humidity, and strain. A lot of us are worried about what's on the outside compressing the tissue, but we probably need to be looking at what's on the inside compressing the tissue. And this is Dr. Spriegel and Sonnenblum's work again, and they were really looking at wheelchair seating. And what they found when they were looking at tissue strain is, interestingly enough, there are really three types of coccyx morphologies. Type 1 is your coccyx is slightly curved forward and pointing downward. Type 2, it's more curved and points forward. And then type 3 is almost J-shaped and it's very sharply angulated. And what we don't know from this study is, we do know from this study is that the different morphologies or shapes of your coccyx actually will change or differ in terms of how much tissue compression occurs and how much strain occurs down at the bone and at the muscle level. But the interesting thing is that we don't yet have that correlation about the shape of your coccyx and in the clinical setting. And we're certainly not throwing everybody in an MRI to see what kind of shape of coccyx they have and then try to determine if they are at bigger or less risk. We don't know that data yet, but it would be great to find out. We do know in the Japanese population that they have a higher rate of pressure ulcers in the sacrum as compared to other ethnic groups in the world, and they do have a J-shaped coccyx. Okay, and here you can see some of that skeletal displacement when you elevate them, and you can see the big elevation and the skeletal displacement of the muscle and bone and compression from the inside. So we have to worry about the outside, and we have to worry about what might be on the inside too. We do know that shear, again, will enhances that mechanical loading damage. So, and if you have some shear, that shear strain, you don't need as much direct pressure. So that's vertical right on down to occlude that vascular supply in the muscle. And remember what Geffen said, your muscle is more susceptible than your superficial tissues. And it's that cell deformation that actually starts that whole process. And really, here it is. So you have that mechanical load, you have the deformation of the tissue cells, and then the cells within a few minutes start to disrupt. Their cell membrane is destroyed, you get leakage into the surrounding interstitial tissues, you end up having cell death, and it happens rather quickly, within a few minutes, and tens of minutes, where when you have ischemia, you have the occlusion of the blood and lymph. And then what happens there is you have that shortage of oxygen, accumulation of waste, and it causes cell death more slowly. So think about it, it's a crush, the deformation of tissue cells is like a crush injury that starts setting up that inflammatory process, where ischemia is a little less immediate, but still as detrimental. Again, how long does it take? And this is what we see a lot of pressure injury litigation. Is it tens of minutes or is it several hours? And so ischemia, if it's more related to ischemia, it's a several hour event, whereas when you deform those cells quickly, it's not very long, tens of minutes. So it doesn't take very long. We underestimate the role of the lymphatic system affected by pressure. Again, think about when you have this inflammatory response from your cell death and your ischemic and reperfusion injury, you're now going to have this rush of fluid and edema. You depend on your lymphatics to clear that, clear the bacteria, clear the metabolic waste. And guess what? If you've crushed the lymphatics, you're not going to be able to clear that. So you are actually going to have that inflammatory response and tissue and cellular response to be amplified because your lymphatics are not working. We have a vicious cycle as a result of the cell deformation. So the cell degrades, you have increased free oxygen radical species, which increases your electrolyte changes in your mitochondria, it increases your inflammatory mediators that come in, your vessels start to leak, you have this fluid accumulation, and then you actually compromise your lymphatics even more, you get more, and your vascular system, you have oxygen deficiency that causes more damage, and you have edema, and it goes on and on and on. So really it's cell deformation as well as ischemia and tissue death that occurs that gives you that pressure injury. So, we always think, is it a top up or bottom down? So those deep pressure injuries, they are bottom up. We just don't see them right away. And it may take, as you know, several days before we actually see changes in the tissue, which is why some of the newer diagnostics out there are trying to look at tissue underneath. And I just want to say it's just rarely about one biomechanical force, which is why we want to start thinking about using a multi-layered foam dressing to address these issues. They want to address shear, which is that combination of gravity and friction and the force on the skin as it pushes down and strains that tissue. And we want to stop that friction because alone, if it's just you can prevent those superficial wounds because of that friction. But when you add the gravity, it adds and produces shear. And then, of course, you want that multi-layer silicone foam to prevent moisture from getting into the area. And you want to be able to control that microclimate underneath that dressing. And these dressings do a really, really good job in doing that. Now let's talk quickly about medical device pressure injuries. We've seen a lot of them, probably more so with COVID lately. And again, they're very, very similar to other pressure injuries in that you have an external force. There's tissue deformation, there's vessel occlusion, there's transepidermal water loss. But what we see with most of these medical device pressure injuries is that it is definitely changed by humidity and temperature increases and occlusion. So what we have is when you've done that, those biochemical tolerances, your tissue tolerance are reduced. And when you start looking at the data on the device-related and medical device-related pressure injuries, you can see that they are a lot more pronounced than we'd like to think that they are. They're much higher rate than they are of plain old pressure injuries. And you could see that they have a tendency to be more in critical care areas, operating room areas, and neonatal patients. The problem is that I think you would, if you were to really do a deep dive, you would probably find almost the same amount in long-term care and possibly home care, but we just don't have people going out there and looking at that specifically. But I did do a study way back in 2007 and looking at pressure ulcers, and actually my study population, as it turned out, 50% of them had their pressure ulcer related to a device. And then the other work out there has been done by Mary Arnold Long with regard to these alternative settings. So they really are everywhere. So when you're thinking about using a multi-layer silicone foam to prevent these pressure injuries from devices, think about, again, how the device will, and the shape of that device will impact how you deform the tissue. So you're going to think about your dressing selection, the size and the shape of that dressing selection based on the size and shape of not only the direct contact with the skin, but remember that that shear strain also is further out. And really there's not a lot of huge differences between plain old pressure injuries and device-related pressure injuries. And the reason this says ulcers is because the rest of the world still considers these ulcers and not injury. And the Geffen is from Israel, and this is a international journal, and the Journal of Wound Care is really out of Europe. So that's why you see the word ulcer. So I don't mean to offend anybody. So the problem with the device-related pressure ulcers is that there are a lot of generic designs out there. Many hospitals do only stock one or two sizes, so we don't really get a good fit to start with. Our patients change under our care. I actually had somebody this morning who was doing great. She went into renal failure. She gained about 7 liters of fluid, and now she has horrible edema. And because of that, she developed a deep tissue injury from a medical device. We do see most of these from the head up or the neck up, although it can happen really anywhere. Again, anytime there's sweat underneath or increased temperature, that is a huge red flag to say you are at big risk for a pressure-related injury from a device. Okay, so there's a great framework, and I'll refer you just to this article. It's in the Journal of Advanced Nursing from Coleman, who essentially summarizes all these concepts that I talked about earlier. So let's talk about the role of dressings in biomechanics, because if you can control the biomechanics, then you are going to help you prevent pressure injuries. So again, we want to think about these multi-layer silicone foam dressings for friction, shear, moisture, and pressure. So I think when we think about using a dressing for pressure injury prevention, we have to think about some of the things that we were told and some of the myths that we still have ingrained in our system. So in the early 2000s, a lot of these multi-layer foam dressings came out, and they were saying, oh, it reduces pressure. And we were taught that you needed at least 4 inches of high quality, high density foam to redistribute pressure. And we had really no data to support that. So we kind of like, oh, you know, that's not right. That's not right. But now we have a lot of data to support using these multi-layer silicone foams for pressure injury prevention. So what are those ideal characteristics? Well, you need an outer surface that has a low friction material, and you need that surface to have a low friction coefficient. And when that is applied to the patient, that needs to be transmitted to the patient's skin. It just can't, act independently. And you know what? It has to stick. A dressing that doesn't stay on doesn't work. You also have to have something that alters the microclimate underneath that dressing and prevent things from getting into the area, which would alter the microclimate or the barrier of the skin. And then you also need something that is soft, but that actually does some mechanical absorption from the patient's own skin, so sweat and so forth. Okay, so here's some of that history. So in 98, there were people who were trying to do pressure injury prevention, and they started with, hydrocolloids. In 2006, we first started seeing polyurethane foam. 2007, the ceramide-infused hydrocolloids on the hips. 2008, films and hydrocolloids on the nose. 2011, polyurethane foam, nose, hydrocellular foam on the heel. And let's look at that pressure injury rate. So these studies were done, the pressure injury rate when you use this for prevention ranged between 3.6% and 60%. So obviously some of these dressings really didn't work, right? Who wants a 60% pressure injury incidence? Now let's look about the next step. And this is where we found that silicone foam was introduced to the marketplace. So in 2012, there was a study showing that using silicone multi-layer foam on the sacrum. 2013, another study, much larger, aggregating patients and used a multi-layer silicone foam for the sacrum and the heels. And guess what? The pressure injury incident rate in this group with this construction was 1.0 to 3.1%. So very, very low. And obviously we've made a breakthrough. So what is silicone? It's really silicon and oxygen, and then they add some organic groups. And then we have to realize that it comes in different consistencies. So silicone is soft and tacky, but it can be a little bit harder, and it can be very, very soft and almost liquid-like. So you have to have the right kind of silicone, but we do know that silicone adheres to dry surfaces well and not well to wet surfaces. Now, silicone adhesives work very differently than our traditional adhesives. First of all, they have a low surface tension. And so what happens is that when you place it on skin, the application strength is consistent over time, because you can see in the picture on the left, it doesn't go into the skin. It just forms a nice adhesion between those top of those cells in those nooks and crannies, and it conforms quickly. And the reason we all love silicone is when we peel it, it doesn't have a big peel force. And you can see over on the right, the way the silicone stretches allows that force to be very little. So you're causing less sensitization. Remember, we talked about sensitization of skin over repeatedly can actually lower your tissue tolerance. So you want to use a silicone adhesive on your foam, multi-layer foam dressing, just so you reduce that sensitization. It's nice because you can reposition if you need it. You pick it up, you take a look, you can put it back down. It doesn't do well against plastic. And the nice thing is that there are no traumatic removal of skin cells. But I do want to say a little bit about that because I'll show you a study further on. Now, acrylate adhesives are completely different. And you know it when you see it because you've seen your patient's skin. Again, so the acrylate adhesives are great because they do stick right away to those top epidermal cells, but over a period of time, they melt in between those epidermal cells. So they fill in those cell gaps. And so these adhesives strengthen over a period of time, which is great if you want something to stay forever. The problem is when you are looking at pressure injury prevention, you want to be able to take a look underneath to make sure everything is fine, right? So what happens is that your peel force is much, much greater because you're trying to pull everything, all that adhesive out, even those adhesive in between the cell gaps. So that's why you have increased damage when you see patients using these types of adhesives, but additionally, you're sensitizing that skin. And again, the more you sensitize the skin for repeated damage, you are actually decreasing their tissue tolerance and putting them at risk for a pressure injury just by using an acrylate adhesive. So you really don't want to do that. So what is the evidence on these multi-layer foams? Well, Padula, who is a healthcare economist, actually looked at a whole bunch of data from the Medicare database. And essentially, he found that the use of these multi-layer foam dressings are really part of a great pressure injury prevention protocol. It's a piece, but they do make a big difference. And so when you looked at the data, when he looked at the data, between 2010 and 2015, when people started adopting this addition to the prevention protocol, the significant reductions in pressure injury rates were occurring. And so, he ruled out everything else that could be a contributing factor. His work is absolutely fabulous. And then Janet Raimundo actually looked at prophylactic multi-layer foam dressings applied to the heel in conjunction as part of a pressure injury prevention program. It has been shown to prevent pressure injuries on the heel. And we know both the heel, behind the ears, and the sacrum are one of the largest or the most frequent areas for pressure injury. So here's the data. And this is, again, back off to Dr. Geffen. So he's thinking, well, this can't be true. These little, thin foams, they can't really do a lot. Well, guess what? So he did a biomechanical analysis of these foam dressings with COVID. So what he did was put these multi-layer foam dressings on the chin, the forehead, and guess what? He found that the stress or strain is in the forehead soft tissues were reduced. And you can see the stress by 52%, strain by 71%, and then the chin soft tissue stress by 78%, strain by 92%. Think about what we've been doing with these patients during COVID. They've been proning, they're face down. And guess what? We're getting lots of pressure injuries. And just by using a simple and inexpensive multi-layered foam, especially if you're using something with silicone to decrease that coefficient of friction, you are going to really help your patients. So dressing construction matters. You can see this is a house, not well built, and look what happens to it. Same thing with your foam dressings. So this is an example of dressing construction. And so think about all those forces we were talking about: friction, shear, moisture, and pressure. So think about what goes on to the patient, right? So you want something that is not going to have a high peel force, something that is not, so you can pick it up and put it back down. And that's the importance of the silicone, right? Then you need a foam layer. A foam layer is important for a couple of reasons. one of which is to help wick away some of that moisture. And you also need it to reduce your stress and your strain. Remember, pressure equal force over area. And this is a very interesting dressing because if you look at these little lines here, that actually helps to the dressing and its conformability, because we know all of our patients have nooks and crannies, and you need to be able to adhere to that. The super absorbent layer is also really important because if you actually had a wound underneath and you had a lot of drainage, you want to wick things away and keep it there. But if for those people who are just sweating a lot, you're going to have your foam layer wick everything away and then have it sit in the super absorbent layer. And your moisture control layer, again, actually is helpful in your microclimate. But one of the most important things is that outer covering for a couple of reasons. One, you want it breathable. You want the transepidermal water loss that's coming off, that extra overhydration, if you will, come through and escape somewhere, right? And you need it to have a low friction coefficient. Remember, so one of the reasons some of your dressings aren't staying in place is because the friction coefficient's a little bit too high compared to the external forces being applied to it. So you want something that's going to stay, but you also want to be able to pick it up and look at it and put it back down. And you also want to be able to make sure nothing from the outside, like stool or urine, gets in there. I also find one of the most important things is the application and how you apply it. And this dressing actually has an application enhancement. Most of us find ourselves alone trying to put on a dressing, and we're sitting there trying to hold our patient with one hand and, you know, put the dressing on with the other. So this application enhancement allows you to peel back the bottom and then put it on, and then you can place it the way you want, and then you can finally peel off the top, and you've got a great seal, because that's really important. Now, I alluded to this before, not all silicones are the same. Now, as compared to the acrylate dressings, which take off a lot of epidermal cells when you pull off the adhesive because of that high peel force, silicones, although they have a less peel force, can be different. So you want to ask about their epidermal cell data or removal, or how much epidermal cells are removed upon dressing removal. And you want to ask your manufacturer, your sales rep, about that. You know, all silicones are not created equal. As I said, they can be gel or they can be really, really thick and hard. So each manufacturer has their own little, proprietary formulation for their silicone. And so some are better than others. So you want to figure out, are they peeling epidermal cells or not? And then the dressing itself, the construction, absorption capabilities are not necessarily all the same. So you're going to want to ask for that kind of data. I've talked a lot about size of your multi-layer foams throughout this lecture. And we have to recognize that all these multi-layer foams are unlikely to be cuttable. Again, because each layer has its own separate job, so to speak, cutting that will actually impair its jobs. It's like cutting the house in half. It's just not going to do as good a job. You can't live in it, right? So you also need a ability to have different sizes. Again, when we talked about stress and strain, it's not only what you want to prevent right at the area of concern, but the strain that you're going to see further out. So for example, you could see over on the right, you have a sacral dressing. It is shaped like a buttocks. It will do the right half, the left half, and the middle. And again, so if you're just worried about the middle, you have to think about the stress and the strain on the right and the left buttocks. And so you need a dressing that's going to address that. Over on the top is a heel dressing. Again, your heel, again, has very little surface area. So you have to spread that out, pressure equal force over area. You have to be able to redistribute that well. And so you do need different shapes. So just think about that. I'd like to share some practical pearls about using the multi-layer silicone foam dressings. First of all, application really matters, okay? If you see this picture here, we're folding the dressing like a taco, and it really makes sense. A lot of people don't apply these sacral dressings really well. They'll get a good seal on the right side, a good seal on the left side, a good seal on the top, but you know what? They don't get a good seal near the anus, and you actually cause this thing that I fondly refer to as a poop shoot. So any effluent that comes from the anus, any effluent that comes from the urinary system goes right into this little gap, and it sits on the skin, altering that microclimate and disrupting that skin barrier. So it's really important that you get a really good seal, and the dressing makes the difference. Some dressings do not seal well down near the anus area, and you need an extremely, extremely dry skin. Remember, we talked about how silicone doesn't stick very well to wet surfaces. So if you have a good silicone that is very forgiving when somebody doesn't have a perfectly dry skin, it really makes the difference. So here we are applying a, I call it prevention by location. So you know that there's certain people who are always going to have problems. And this is a guy that continues to have problems, and on his buttocks, he sits literally in 7 layers of clothes in his wheelchair, and he will not get up. So we are actually living with a multi-layer silicone foam dressing on this guy because it's the only thing that prevents him from opening up. You can see on the left how we can get a really good seal. He's got a very deep sacral cleft, so it's hard to get that good seal, and we're able to do that. And we are pulling off, get that good seal, and then use the device to actually peel off that top layer once we have it well secured. So location is really important. So think about prevention by location. So is it at risk for high friction? So elbows, especially in the COPD patients, they're just going back and forth. They're using their elbows for repositioning. People for shearing, those little frail, little older people, people who are frequently incontinent, people who sweat a lot, people who are morbidly obese, and then of course, people at risk for direct pressure. So we do know that incontinence-associated dermatitis and moisture are key factors. We have to keep that stool and urine away from the area. And again, those moisture-associated skin damage areas result in inflammation, and inflammation impacts the dermis and the epidermis. And again, once you macerate or have inflammation, your cells change shape. So that can add to more issues. So let's think about prevention by history. So this is a guy on the left. You can see how ugly this pressure ulcer was. It was on the back of his calf because he loved to sit in his Barcalounger, and he developed a really nasty wound there. And we eventually healed it, but he would go back and forth because he loved his Barcalounger, and he really didn't want to give it up. So we know that these open close are wounds are related a lot to the tensile strength of the skin, and again, the sensitization of repeated injury. So you have to prevent them. And so getting a good history about, have you had a problem with your skin before? Does it open? Does it open, close? These patients can tell you. And then again, if they have a strong history, if you have somebody who has these recurrent wounds in the same area, think about using a foam dressing to prevent this from recurring. This is another friend of mine who had a prosthesis from issue, and he developed a stage 2 pressure ulcer down at the base of his amputation. And you know what? He's waiting for his prosthesis to be looked at by the orthotist and then refashioned. And how long does it really take? So, in my neck of the woods, we're finding it can take several weeks. The guy wants to work. He wants to go to work. He wants to drive. He is going to use his old prosthesis. So we're going to use a multi-layer foam to protect him from injury from his current prosthesis, but we also used it when he first got his new prosthesis because we know that tissue tensile strength wasn't as strong. We didn't want it to break down. So again, using a multi-layer foam dressing can be very helpful, again, by knowing the patient's history. Oh, I really loved taking care of this patient. She was an older woman, had a stroke. This looks like she has a diabetic foot ulcer, but she does not. This is a pressure ulcer from her wheelchair foot pedal. Because of her stroke, and she was home and not positioning well and not cognizant of her position most of the time because this was her side that had the hemiparesis, she frequently would put her foot down on the foot pedal. We made a number of adjustments with her seating, but again, we had to both treat the wound. But once we healed the wound, we used a multi-layer foam dressing to keep the wound from recurring because some of the issues couldn't be changed, including her ability to be cognizant of the fact of where her foot was, even though we made as many wheelchair adjustments as we could. So we used this as a prophylactic intervention. It was cheap to do once a week. The home health nurse would change it, and she stayed ulcer-free on the plantar aspect of her foot. So let's talk about some practical pearls by the medical device. So the picture on the left is really a bad picture, and I apologize for this, but this is actually at the base of the dorsal foot. So right where the tibia and the foot meets. There are a lot of people who are really rigid there and they have no range, right? So when you end up having a wound on the heel or the toes, what people do is wrap them up, and they usually like to use Conform because it looks nice and it doesn't wrinkle and it's not as bulky. But what happens is that if they have any underlying issues such as edema or peripheral vascular disease, when you stretch that conforming gauze out, it actually does shear strength, and it will actually stretch the tissue over the tendons in that area and cause pressure ulcers. So what a lot of people do where they think they're being cost effective is by using gauze, bunch of gauze, which moves, by the way, underneath these wraps, or they'll use an abdominal pad. What happens is that, again, the abdominal pad gets it to be a little bit bulky. On top of that, that also moves and can bunch up, but it's really not cost effective because you're ending up changing that every single day, most likely because you're dealing with the wound. You can just use a foam dressing in its place of the ABD pad. First of all, you don't have to change it every day. You can lift it up, take a look at the skin, put it back down, and that makes it much more cost effective than trying to use a new ABD pad every single day. Over on the right, this is a cervical collar. We know that a lot of our patients during COVID got hypoxic. Many of them fell in long-term care, and some of them had adverse events from those falls. This is one of those patients. A lot of these times we can't, especially under cervical collars, they're hard to move. We can't move them. We're very concerned that we may do more neurological damage. But again, pressure equal force over area. There's very little area and a lot of force from these collars. The collars are designed to keep that spine in alignment and not to move. So using a prophylactic multi-foam layer dressing, definitely deals with that microclimate because these people sweat under here. That foam collar gets a lot of secretions and it gets a lot of buildup of moisture. So using a multi-foam layer dressing in these kinds of cases really goes a long way. I also like to use them under trach collars because they too get a lot of moisture accumulating and a lot of friction. So I do want to summarize. Thank you very much for joining us today. I do want to summarize by saying multi-layer foam, silicone foam dressings have strong clinical evidence in prevention as well as treatment, but prevention especially. And they have bioengineering results showing its efficacy against friction, shear, microclimate, and pressure. And it's nice to have something other than just our clinical results in the clinical setting, is to have biomechanics support our clinical research findings. And then most important of all, the most expensive dressing and pressure prevention protocol is one that doesn't work. So if you're not using everything you have at your disposal, then it's going to cost you more money. And so it's worth putting on a foam dressing for cost effectiveness and patient outcomes. Again, thank you so much.